Well, thank you everyone for your patience for us getting started. As your reward, I'll talk very fast, and if you already know me talking very fast is kind of scary because my natural speed is pretty fast. But I want to keep us on schedule as best possible. So welcome. I am Kathy Hoke. I am the director of the Network for Public Health Law's Eastern Region, which is situated here at the Francis King Carey School of Law. Thank you for coming to Baltimore, from you from out of town. If you're from in town, thanks for making your way over to the law school. And we hope you enjoy the facilities here today. Before I get into the actual introduction of the network and this symposium, I want to point out a few details. First, there are bathrooms that are when you came in the door, instead of coming straight into the atrium, you could have turned left, and then the bathrooms are on the right, men's and women's. There's also, if you prefer, there are bathrooms past the dining or into the dining area over to the right, past the student mailboxes. There are also vending machines back there if whatever food we're providing for you is insufficient or you have a sugar hankering or whatever your issues are. There are healthy vending machines also with the little green check marks and everything. Over there by the other bathrooms. The other detail I want to point out is today's proceedings are being recorded. As a lawyer, I can tell you in Maryland, I've now given you sufficient notice that you are being recorded. I don't need your permission to do so. For those of us who are old enough, we know that we learned that from Monica Lewinsky and Linda Starr. So that's how I know that. In any case, you would think as a lawyer I learned it some other way, but no, that's how I learned. So those are the technical details for the day. We hope if you need anything during the course of the day, if you need a quiet space to make or take a quick phone call, or you're having trouble with getting internet access, or any needs that you have, please let us know. Folks will be back at the desk. Megan, are you in the room? Megan is not in the room because she's running around doing crazy things because she's awesome. But Megan Grice, who you've probably communicated with on some level, will take care of any of your needs. But if you see anyone from the law school here, just let us know what your needs are and we'll make sure that they're met. So, the Network for Public Health Law. Fortunately, we were lucky when in 2010, the Robert Wood Johnson Foundation decided that state and local public health officials, legislators and policymakers, advocacy organizations and community groups around the country working to improve the public health could use the assistance of lawyers. Lawyers had been not necessarily part of the everyday conversation for particularly local public health departments and even state health departments, let alone legislative bodies. And so they created the Network for Public Health Law. There are 5 regional offices around the country, and we're situated here in the Eastern region, which is the Mid-Atlantic states and the Northeast states. For some reasons that only Denise Chrysler and I could explain, we don't have Pennsylvania, but we do have West Virginia. And perhaps reasons that Sarah Summers can explain, we don't have Virginia. But in any case, that's about the breakup. But the network is staffed with several attorneys in each of the regions. And as I indicated, our customer base is state and local public health officials, probably most primarily, their counsel, anyone who works in any of those offices. But in addition, really that's how we started off. I would say over the years now, the 7 years almost that we've been in business, we are really reaching out to organizations like NASN to say, hey, okay, we now know how this legal technical assistance can work. There are law and policy changes that you want to see happen to improve public health that relate to school nursing. There are impediments to your improving public health or the health of children, legal impediments that you want to try to break through. How can we get around these barriers? Or how do I have to deal with what is a perceived barrier by our law department? And that's what we're here for. And so we're starting to make broader connections with organizations like NASN so that we can really get down into the weeds with particular organizations. So we're so happy to have you here today. The one thing I want to leave you with, well, 2 things I want to leave you with. The first is, if at the end of this day you have any lingering questions, we are happy to answer them. If you, during the course of, after you leave here, you now know that the network exists, it's easy to make a request for technical assistance. You go onto our website, you can just pop in your technical assistance request. You don't have to worry about what region should answer it. It will go to the right place, and you will get, typically within 24 hours, someone will respond to find out more about what it is that your needs are. So it won't end today. Our talk about law and policy and using school nurses to improve public health, and we hope that you'll continue to be part of that conversation. Lastly, I just obviously need to thank some people, because I get up here and say a few words and it makes it seem like I had something to do with today, and I really had very little to do with it. Carrie Lowry, who's up here in the front. Carrie, raise your hand. Carrie has been with us since the start of the network, and I like to tell the story of I knew she was going to be a great hire when I actually had to interview her in a hotel room lobby when it was the first football game of the season on a Thursday night and the Ravens were playing, which is my team. Carrie's a New England fan, but we had, we had shared hatred for the Jets, who the Ravens were playing. So the fact that she and I made it through that interview and decided then that, you know, this was a good relationship has only grown over the 7 years to, you know, really honestly, we're like family here in the network. I think even with my colleagues from the Southeastern and Mid-States region, we feel like a family, but that's how I knew Carrie was going to work out, and I've not been wrong. I did hire another Patriots fan who's in the back of the room also. So clearly I am open-minded to these things. In any case, so Carrie has done a fabulous job getting, gosh, the most remarkable speakers to come in and talk to you, organizing the event, and really, I think, shining this up. To have the room this full is the reward for all of her efforts. And then Megan Greist, our program manager, now chief of staff for both two programs that we operate here at the law school, has done everything behind the scenes. She was here until last night stuffing your folder so that when we all came in this morning to help, she's like, nope, done. So I don't have any paper cuts, and you know it's going to be a good day for me. But that's really, and we actually, I can tell you, we have another event tomorrow and another event Thursday. So the staff here for the Legal Resource Center and the Network for Public Health Law are phenomenal, and I just need to give them that shout out today. So on that note, I'm going to turn things over to Donna to talk about NASN and to welcome you as well.
Thank you so much, Kathy. Thank you, Kathy, and good morning, everyone. I've got some notes here because I figured out I had enough words that would fill 3 minutes, so I don't want to use too many of them. But I have to tell you, from a personal standpoint and a lifelong Perry Mason fan, this is cool. So I just want to say, and I'm going to ride a little bit on top of Kathy's words of thanks. I mean, this is a wonderful collaboration, and I want to tell you a little story about how it started. This day of learning and connecting began with an initial meeting of two leaders and advocates for children's health, NASN President Beth Maddie, and you just met the Network for Public Health Law Eastern Region Deputy Director Carrie Lowry. They met together at a meeting in December 2016. I would like to note that we're probably about not too much of a gestational period for what their conversation brought to us today. So I'm really grateful that that idea for this symposium occurred on a day in December not that long ago. This co-sponsored event brings forth the best of NASN and the network on this topic of advancing a culture of health through understanding the legal strategies that school nurses need to know. I'll give you a little snapshot of NASN. NASN began 49 years ago as the Department of Nursing and the National Education Association. And we have someone here from AFT, Chelsea is here. Hi, Chelsea. We began in your organization as a department. And then by 1975, NASN formed its own 501c3 organization. And the organization at that time had two goals. Those goals were to operate exclusively as an educational organization on a nonprofit status, and to promote and advance the quality of school health services and health education throughout the nation. I can say that decades later, NASN continues to pursue these goals. Our vision is vast. We want all students to be healthy, safe, and ready to learn. And our mission moves us to focus actions to optimize student health and learning by advancing the practice of school nursing. The NASN board adopted a new strategy this year under Beth's leadership. And one of the concepts infused throughout the plan is partnerships. In fact, one of NASN's goals for the next 3 years is to forge shared leadership in the development of healthy communities. And today's meeting exemplifies that goal. And we're very excited that we're able to connect together for this. In 2016, NASN commissioned a school nursing workforce study. No one else really knew what the workforce was in recent years. And so you'll hear data from that study in several presentations today. But one data point I want to leave you with is that there are 95,776 full-time equivalent school nurses in our country. And I think we need to know that number, because a current narrative is there just aren't nurses. They may be inequitable in terms of where they are. They may not be matched perfectly with the needs of students where they are, and we'll hear more about that equity today. But we are excited to be part of this. This is the first of our Forging Shared Leadership. We just adopted the plan in February. I'm so thrilled that we can join with the network to allow us to really look at the culture of health, and school nurses leading that. Enjoy today.
So if our first panel lasted class is super informal.
Good morning, everyone. Thank you for giving me the opportunity to speak with you this morning. I'm Cheryl DePinto, and I know many of you in the room in my usual role with the Maryland State Department of Health and Mental Hygiene. But I'm really honored to be here today on behalf of the American Academy of Pediatrics Council on School Health to speak with you about the policy statement that was released last year regarding the role of school nurses. What I'd like to do this morning in my brief time before you is to describe the AAP and its interest in school health, and to give you a brief description of the policy statement related to the role of school health, and then also just present some considerations for school nurses as they work with pediatricians to implement the recommendations in the policy statement. So first, for those of you who are not familiar with the AAP, I just wanted to give you a little bit of background. The American Academy of Pediatrics is a group of pediatricians and other people interested in pediatric health. And the mission of the AAP is to attain optimal physical, mental, and social health and well-being for infants, children, adolescents, and young adults. To accomplish this, the AAP supports the professional needs of its 66,000 members. Some of the activities are conducted through a group of 89 councils, sections, and committees which focus on a broad range of interests of its members, including a variety of medical specialty and subspecialty, advocacy, and public health interests. Some of the activities include strategic planning, advocacy, research, community-based interventions, policy, and clinical guidelines development. Now, the Council on School Health is one of the councils within the AAP which seeks to promote school health policies and practices that ensure health and safety of school-aged children. The 458-member council is dedicated to maximizing personal health, academic achievement, and lifelong success of children. The COSH operates through a 15-member executive committee, of which I'm a member, and we have approximately 19 policy statements related to school health. COSH affirms excellence in school health as being a model where school physicians work side by side with school nurses, and supports the concept of coordinated school health that's promoted by the CDC and the ASCD's whole school, whole child, whole community model. The COSH acknowledges also the important role of school-based health centers, and also believes that schools are an important player in the serving of public health functions. AAP policy statements are developed over a very lengthy period of time. It usually takes approximately 2 years for a policy statement from its inception all the way to its publication. The policy statements undergo rigorous reviews by both internal and external stakeholders, which includes some of our partners, like the National Association of School Nurses, in its review. Its intended audience is primarily practicing pediatricians. However, policymakers and other stakeholders are also often recommendations for them are also included in many of the policy statements. Regarding the policy statement on the role of school nurses, this policy statement really makes a clear case for the value of school nurses and really affirms the AAP's commitment to school nursing. It presents information related to the legal, medical, and societal changes that have formed the context for school nursing in our modern times, and it also shows how laws and legal challenges and changes really shape the context in which school nursing operates. The policy statement concludes with a set of 4 recommendations, and so today what I'd like to do is outline the content of the policy statement and then also show how school nursing can partner with pediatricians in the implementation of these guidelines. I also want to mention that this policy statement is one of many policy statements by the American Academy of Pediatrics, and so the information in this policy statement is really supported by a myriad of other policy and technical and clinical guidelines. So it does not go into real specific details on the day-to-day activities of school nursing, but really focuses on the context in which school nurses operate. Now, one of the most important aspects of the policy statement in terms of the value of school nurses that the AAP embraces is the fact that school nurses really function as an extension of the medical home. And the statement describes how school nurses connect families to medical care and both promote as well as support coordination of care. We know that school nurses provide chronic disease management and also partner with both primary and specialty healthcare providers to really manage in the school setting some very complex and complicated medical conditions. School nurses also support implementation of the federal laws that are designed to promote inclusion and to remove barriers to education for students with special healthcare needs. As an extension of the public health system, we know that school nurses engage in a variety of health promotion and disease prevention activities, such as obesity prevention, immunization compliance reviews, tobacco use prevention, substance use education and prevention services, mental health services and referrals, adolescent transition, promoting school attendance and high school dropout rate, amongst many, many other things. Now, the policy statement outlines these different contexts in terms of legal, medical, and societal changes that form the context for school nursing. 2 of the main legal issues have to do with the set of laws from the federal government that are designed to support inclusion and educational success for children with special health care needs. I know that later on in the day you'll hear a lot more detail about these laws, but from the standpoint of the way in which it really changes nursing practice and their interactions with healthcare providers, these laws are incredibly important. Also, the confidentiality of records with HIPAA and FERPA, the Federal Education Rights and Privacy Act, are also really important legal contexts in which school nurses operate that private pediatricians and other healthcare providers really need to understand the ways in which these laws affect nursing practice within the school setting. The increased complexity and acuity of the medical conditions that our children face today also shape the ways in which nurses act to promote access to care, referrals to community providers, and collaborations with school-based health centers. And nurses also work with planning for emergencies and emergency preparedness within schools, not only in terms of medical emergencies, but also disaster and other types of crisis interventions. The types of societal changes that have really shaped nursing practice also is the interactions between the medical home in terms of referral, working with insurance in terms of getting students connected to Medicaid or other types of social services for which they may be eligible. Public health interventions such as immunizations, obesity prevention, tobacco prevention are also important to the types of societal changes that nurses have to be prepared to respond to. Now, in terms of the policy statement recommendations, as I mentioned, there were 4. The first one has to do with advocacy and really states that pediatricians should be advocating for a nurse in every school with collaboration with a school physician. And while this is an ideal, we know that this may not always be necessary. As school nurses work with pediatricians to advocate for school nursing, one of the things that you really need to consider from a legal and operational standpoint are some of the rules that may affect you in terms of your ability to interact with legislators. We know that for those of you who work for state and local government, we are sometimes constricted in our ability to interact on advocacy efforts around laws. So one of the ways to address that is to be able to be armed and ready with data and information that your advocates can use to promote your best interest. The second recommendation has to do with information sharing. So pediatricians are recommended to ask about school issues during their health encounters with patients. And the policy statement talks about sharing this information directly with the schools, and then goes on to talk about how electronic health records within the provider offices can be used to facilitate this information sharing. Some of the considerations around this information sharing, clearly, as I mentioned before, some of the confidentiality laws around information sharing, but also when we think about electronic medical records, we know that they're designed to facilitate communication and information sharing. However, they can also present some obstacles when we think about ways in which electronic information needs to be secured, certain access limitations that need to be put in place. And then as you think about ways in which you can innovate and having different information systems communicating with each other to generate reports, it can also complicate systems when, or the situation when the electronic systems are not compatible or interoperable. The third recommendation has to do with communication, and as I already mentioned, being able to communicate also relates to not only the confidentiality of records, but also the establishment of agreed upon methods of communication. And school nurses are very familiar with the kinds of forms and doctor's orders and other healthcare provider orders that you receive in the schools. So in order to promote effective communication, one of the ways of being able to do that is with standardization and the user friendliness of forms. And one of the ways to be able to achieve that is to include healthcare providers in the development of these forms so that they can be maximally useful and really promote communication of the most useful and most helpful information. Inclusion of health providers in the development of the individualized healthcare plans, as well as in transition planning for adolescents, is also another way in which strong communication practices can be facilitated. And the last recommendation has to do with team-based care, and it tells pediatricians to include school nurses as important team members in the delivery of health care to children and adolescents, and in the design of integrated health systems, which also includes school-based health centers. So to implement a process for team-based care, school nurses and providers must really be able to understand the practice and scope of practice laws in which school nurses operate. Many pediatricians may not understand the concept of the Nurse Practice Act and how it is applied in the school setting. especially in regards to delegation of nursing practice. Now, we already heard that there are many school nurses around the country, but there may not be enough of them, so the idea of delegation is a really important aspect of the routine nature and the way nurses practice. But in a school setting, delegation can take on many, many different forms, and there are a lot of implications in the way in which delegation is used in schools in terms of its application to applying the federal laws related to inclusion and accommodations for students with special health care needs. Specifically, the policy statement talks about supporting the use of unlicensed assistive personnel. However, there is a strong statement in there about the fact that there needs to be a real balance between the use of unlicensed persons in a school setting and the need to advocate for school nurses. And so we are right with you with trying to make sure that delegation of services is safe and really truly meets the needs of students, but all within the context of nurse practice acts, which are variable across the country. So in conclusion, school nurses play a really valuable role in maintaining the health and well-being of students, are important collaborators in pediatric team-based care, and can assist pediatricians in implementations of the recommendations from the American Academy of Pediatrics. Thank you.
Good morning, and I am happy to be here. My name is Robin Gilden, and I am with the University of Maryland School of Nursing, just around the corner. I am with the Family and Community Health Department. I also am Director of the Environmental Health Education Certificate, and I am here to talk to you about assessing and addressing environmental health issues in the school setting. So this is what I hope you get out of this short presentation, and I am happy to share the presentation with the organizers, and if you have any other questions, I'll leave my cards, so please do contact me. So here we go. So why schools? Well, there's 74 million children around the country and 3.5 million teachers who spend 9 to 10 months a year. And there are indoor and outdoor spaces which all can have environmental contamination. And the reason we're so concerned is because children and pregnant women who are, or potentially pregnant women, which a lot of teachers are, or school nurses might be, are considered particularly vulnerable. Children are more vulnerable because of the hand-to-mouth activity. They're lower to the ground where contaminants settle. They play outside in the dirt. They eat more and drink more per body weight than adults. They have limited selection of food. I don't know if you've seen what variety of food the kids eat in the cafeteria, but and their various body systems are still developing, like their nervous, immune, reproductive systems, and how they detoxify chemicals. They're also exposed from a lot of different routes. They're in their diet, in schools and daycares, in gardens and yards, and in the home, and they have a longer time for the effect of exposure to impact their health. And the fetus is of concern because there are critical points in development where just the wrong toxic hit can have lifelong effects. In fact, one study found that was able to determine that indoor air concentrations of pesticides correlated with umbilical cord blood. So there's a variety of different aspects of indoor air contamination or indoor environmental contamination, and the biggest one is air quality. Poor air quality in schools can cause health effects, including asthma and respiratory problems. This can lead to a variety of complications, and there's several sources of air quality contamination. The first is volatile organic compounds, or VOCs. These can be found in solvents, aerosols, cleaning chemicals, and art supplies. VOCs are organic compounds that can turn into vapors and gases easily. They're made up of carbon, and sometimes they're attached with other chemical or elements, sorry. They are released when you use them or sometimes when you store them. And they can cause a variety of different health effects, particularly with the nervous system and reproductive systems. Mold and moisture can cause asthma and allergic reactions. And they also can cause hay fever type symptoms such as sneezing, runny nose, red eyes, and skin rash. These can be immediate or delayed. Molds can cause asthma attacks in people who are allergic to mold. And in order to remedy this, you need to control the humidity, fix the leaks, and get professional help. Because when you see mold, like on a ceiling tile or around a bathroom, it's usually very bad. There's a lot of mold is sometimes you can't see it, but it's there, and that might be causing respiratory distress in your sensitive populations. Bus diesel. Almost all buses are diesel. They can put off particulate matter, volatile organics, and other carcinogens. So the ways to control bus diesel is to reduce exposures to the kids. Don't let them play in the area where the buses are. Don't let them have them open the windows, and then also control the idling of buses at the school where they pick up. And also, some programs are retrofitting diesel buses to help them clean up. Pesticides, a passion of mine, that's what I did my dissertation on. A pesticide is meant to prevent, destroy, or repel or mitigate any pest, whether that pest is an insect, rodent, microbe, fungus, or lice. And it usually attacks, especially for insecticides, in the nervous system or the reproductive system, and in high enough doses, the humans as well. And they're prevalent in our society. And I guess I don't really have to go too much into head lice, but it's really important just to know your county's policy, whether it's a knit or no knit policy. And this is more for communication home than for you at school. But the biggest thing is to prevent the lice from spreading, and it's not actually a public health issue because it doesn't carry any public health diseases, but it's annoying and it's really hard to get rid of. But so there's ways you can prevent it, ways you can treat it, and if you look on the head lice, EPA's head lice page, it has all of the recommendations. Bed bugs. So I've heard that this is a common, or becoming more common. And this, again, is an important communication home. Heat is really the best way to get rid of it. Either put clothes in the dryer for 30 minutes to kill bed bugs, or if it can't go in the dryer, to steam clean, or get it steam for about 90 minutes. To 120 degrees. Use mattress and pillow covers, monitor to make sure that you've gotten rid of the problem, and then IPM is integrated pest management, where you use pesticides as the last resort. And this is a whole section on IPM, integrated pest management, at school. And So you see here up in the corner, oh, shoot. This graphic right here, it starts out with cultural, and then it goes into physical, mechanical, sorry, and then biological, and then chemical is the top piece that you use sparingly at the end. And this web link is for a wonderful set of webinars, and they're still going on. And it's really important to consider how the grounds are also treated. Lead in drinking water can also be a huge issue, especially if the building's older or it has, you know, lead pipes, lead solder. It can cause neurologic anemia, renal damage, learning and behavior, and cancer, a variety of cancers. And children, again, are more susceptible to these issues. And the only way you can know if there's lead in the water is to test the water, use an alternative drinking source if there is water, and then to remediate by a professional contractor. Radon is a naturally occurring radioactive gas. It is the second leading cause of lung cancer. A national study found that 1 in 5 schools have at least one classroom that is elevated in lead. So this is the graphic for Maryland. And you can see that the highest zone is red, and this is in the middle. And this is a schematic of a school, and it shows the 4 picocuries per liter is the cutoff for EPA to remediate. And so you see that it's sporadic. It's not all high levels. So the only way you can know is to test and then remediate. Asbestos, some of the older schools may have asbestos tile. School of Nursing is going under asbestos remediation right now in the old building, which can lead to a variety of different cancers. One in particular is called mesothelioma. It's almost directly expressly related to asbestos. And then also asbestosis, which is a scarring of the lungs. And the only way to get rid of this is a professional contractor. And so these are just a bunch of resources. The Alliance of Nurses for Healthy Environments, which I also belong to, and NASN is on the steering committee, and they were part of the development of the Alliance of Nurses for Healthy Environments. So we have a whole bunch of resources for school nurses. The EPA Schools for Tools, the Center for Health, Environment, and Justice Green Flags program. The Healthy School Network has a whole list of things for school nurses. The EPA School IPM website, and then I threw in this one, the Children's Environmental Health Network, Eco-Healthy Childcare program, because a lot of your schools also have Head Starts or early learning associated with them. So it would be important as the school nurse to also know those resources. And so if I have do you have a few minutes? Okay, cool. I'm just going to show you. Ask me later. Don't enable. Come on. Okay, so here's the IAQ Schools for Tools, Health Professional Resources, Case Studies, Green School Initiative. So this is all Green School Buying Guide. And it's really important for nurses to be on the discussion on the purchasing. I took out a slide on food because you guys don't really deal so much in the food, but there's a whole bunch of things that you can talk about with the cafeteria manager. The sustainable local farming food network, because there's avoidance of pesticides and growth hormone and antibiotics. It's just, there are so many places where you can have real effects. So thank you very much for your attention, and I'm happy to answer any questions at the end. I'll get this too.
Hi, good morning. I'm just going to pull up my PowerPoint. So I'm Sue Fothergill, the Associate Director for Attendance Works, and I'm here to share with you some opportunities through the Elementary and Secondary Education Act and the most recent iteration of that federal law, the Every Student Succeeds Act, ESSA or ESSA. It's been confirmed, you can say either. On a health panel yesterday. So one of the things to know about Attendance Works, we're a national initiative. We are focused on improving outcomes for kids by ensuring that we're taking a holistic, proactive approach to improving attendance. We build public awareness about this issue of chronic absence, which is a newer measure of looking at kids missing too much school, and I'll talk a little bit more about that. And we want to create political will, state campaigns, and improve policies and practices around improving attendance for young people. And there's this critical opportunity in really leveraging the better health coordinated services for young people to improve their attendance. One of the things to know is sort of how are we measuring chronic absenteeism, and what do we think about missed, lost instructional time, and what research is really telling us about the rate of absenteeism and its impact on educational outcomes. So one of the most significant shifts that we're focused on is this idea of all lost instructional time for any reason, whether those absences are excused, unexcused, or due to suspension. And so it's a change from focusing only on unexcused absences, which is known as truancy, and saying if a young person's out of the class and they're missing 10% of their days on roll, or about 2 days a month, that young person is missing too much school, and they're potentially on track to they're potentially falling off track to academic success, even as early as pre-kindergarten and kindergarten. It's different than how schools have traditionally measured good attendance. They've mostly focused on something called average daily attendance. How many of you are familiar with average daily attendance or heard the term? And so what that really tells us is the average number of kids that show up on any given day. If you have a school with 200 kids and 10 of them are absent, that's a 95% ADA. And so 95% in school language, right, an A is an A, except in this case, the question is, who are those 10 kids? And how often are they missing? And are they missing enough school to be off track academically? And why are they missing school? Do we have, for example, a young person who's missing school because they have untreated or unmanaged asthma, and they need a better asthma management plan? I've been in situations where I've seen kindergartners missing 40 and 50 days of school because of asthma, which should never happen. The other thing, again, back to the truancy language, the shift from focusing, and this is Baltimore City where we're sitting today, the shift from looking just at truancy to also paying attention to chronic absence allowed us to identify many more young children who were missing so much school as to be off track academically. So if you notice the bottom line in front of you, you'll see that that bottom line were the kids that we were flagging based on truancy. Far fewer children in kindergarten and first grade are truant from school, right? They usually come with doctor's notes. My kindergartner had a stomach ache. My kindergartner was up last night with coughs and wasn't breathing, so I kept them home. And so when we look at chronic absence and we say who's missing 10% of their days on roll, you see we're flagging many, many more children that are at risk based on their attendance. The other thing to know is that it's easy not to notice when a student may be missing too much school. 10% of the school year is about 18 days of absence or more if a child is missing more than 10%. And it sounds like a lot, but it's easy not to notice because oftentimes it's sporadic. It's a couple of days here, it's a couple of days there, and they add up over time. And when it happens month after month, it can be a real problem for academic success. The other thing to know is that the first ever national data set on chronic absence was released by the Office of Civil Rights and through the Civil Rights Data Collection Tool. They measured the number of children K through 12 that missed 15 or more days in the 13-14 school year. And they found that more than 7 million children were chronically absent across the country, or about more than 6 million children, or about 1 out of 7 kids. They also found that 50% of all of the chronically absent students are located in just 4% of our school districts. So we have widespread chronic absence across our country, and then we also have very high levels of chronic absence in certain districts. As our knowledge about this issue progresses, there is an opportunity through the Every Student Succeeds Act to more closely pay attention to attendance and to link school-based health services to supporting improved outcomes for kids. And so the key levers in the Every Student Succeeds Act are the state accountability system. States must create a new accountability system, and every state is invited to create their version of accountability with some key framework defined in the plan. Through state report cards, so not just reporting on the measures that are in the accountability rubric, but what other measures might we want to report on our public report cards that might create some public accountability? For example, nursing to student ratios and information about health could be publicly reported and made accessible. Needs assessments will be required for schools that are identified for comprehensive or targeted improvement. The needs assessments will include the measures in the accountability rubric that states choose, but it can go beyond that. What are the kinds of questions that you believe as nurses and practitioners that should be a part of a needs assessment when determining what are the appropriate actions to really turn around the academic success of young people in the building? And then finally, professional development for staff. So with the passage of the Every Student Succeeds Act, there was an addition of a school quality indicator, which moves us just away from just test-based accountability. And schools were invited to create and identify measures of school quality. What makes chronic absence uniquely suited to this particular criteria or particularly suited to the school quality indicator are the criteria in the law, which says that the measures chosen must meaningfully differentiate between school performance, that the measure must be valid, that it's connected to academic outcomes for young people, that it's reliable, and that you can that you collect the information the same way across the state, and that that data can be disaggregated to the school, subpopulation, or individual student level. As a result of chronic absence, first of all, being so highly correlated to outcomes for kids, and because of its usability as a measure of school accountability based on the criteria, of the 13 ESSA plans that have been submitted so far, 8 of them include chronic absence and another 2 include a measure of attendance. We know there are another 37 plans that are still in draft, and that's your opportunity to weigh in on where the states are still determining their state plans, and many more of those in their draft plans include chronic absence as a measure of school quality or plan to report on chronic absence like the state of Kentucky. Maryland, since we're in Maryland, just to quote that, Maryland's draft plan currently has chronic absence as a measure of school quality, and it's weighted at a 15% marker in the overall plan. So the consequences of chronic absence, there has been a myriad of research on the relationship between missing 10% of your days on roll for any reason and academic outcomes for kids. And we just have to acknowledge at this point as a nation that frequent absences from school can be devastating to a child's future. Chronic absence in the early grades, even just in kindergarten, is correlated to young people being less likely to be able to read on grade level by 3rd grade. And we already know that when 3rd graders cannot read, they are 4 times more likely to drop out of high school. We also know that chronic absence in middle and high school is a better predictor of high school graduation than any other measure we can use for young people. Working to reduce chronic absence can serve as a unifying common goal. It can be an effective tool for resource allocation, and it's an easy to understand measure of progress and success. You can see the changes in real time. You can monitor your interventions. You can meet bi-weekly and monthly as health practitioners in partnership with your schools to see if you're getting outcomes around the interventions you're putting in place. One of the things, before I keep going, you pointed out mold. There was a particular school that was experiencing high rates of chronic absence, and when they started to investigate which grades were most affected and which classrooms were most affected, they found that the classrooms that had mold in them, surprise, had higher rates of absenteeism, both for the teacher and for the kids, because they were getting triggered. There are a lot of examples of interventions, but I just wanted to point that out. So solving chronic absence begins with identifying for your school or community what are the most significant drivers behind absences. There are a lot of reasons kids miss school, and chronic absence is the tip of the iceberg, and then the reasons are underneath. And so where there are opportunities to connect the relationship between student absenteeism and student social, emotional, and physical health is where you can play a key role. Students come to school with baggage, and some students have far greater burdens to bear. Solving chronic absence is about removing those barriers to learning and creating safe, supportive, and engaging learning environments. In communities with concentrations of chronic absence and poverty, schools and communities must realize the widespread impact of trauma and design supportive environments that recognize that healing happens in relationships. The framework for reducing chronic absence is a public health approach, so this should look familiar to you, and it begins with prevention. The foundation of chronic absence prevention is creating warm, welcoming, engaging, supportive environments with strong site-based practices and a commitment to using data to coordinate and organize a multi-tiered system of support. Taking action in Tier 2 requires understanding for your communities what is going on and why are kids missing school, developing, implementing, and monitoring prevention and intervention strategies. And when you do intensive work for Tier 3 kids, like coordinated healthcare and case-managed approaches, it isn't enough without making sure that they are welcome to school every day and have positive, personalized support from the people in the building. And nurses can play a key role in helping to build relationships between students and families and schools, because oftentimes vulnerable populations, vulnerable students are the ones who feel most alienated. The shift from truancy to chronic absence invites a holistic problem-solving approach. Addressing health-related absences requires a coordinated system of care, and health practitioners and school nurses are uniquely suited to help schools and school systems transform their strategies to make a difference for children. Just a quick example, because I'm running out of time. There are a variety of challenges that schools are experiencing related to health, and the most important thing to recognize is the needs assessment, so that we're identifying the right drivers and putting in place the right strategies, like an asthma-friendly schools initiative, or a walking school bus, or better nutrition, or improved integrated pest management, so we're not triggering asthma. Healthier students are better learners, and with that, I just want to point out a couple of resources that have been created in partnership with the Alliance for a Healthier Generation and the Healthy Schools campaign. We have 2 toolkits for you. One is about ESSA plans in particular, and how healthcare providers and health practitioners can play a role in informing what are in those state plans. All states are required to have very active public engagement strategies to get informed from the public about what should be in their plans. And then the second toolkit is specific to site-based strategies to improve health outcomes for kids and improve their overall attendance. Thank you.
Good morning. My name's Beth Maddie, and I'm the president of the National Association of School Nurses, and I just want to start by thanking all of you for being here today and our speakers. So I've communicated with some of you, and I really appreciate you coming and sharing your information. It's really been quite interesting and very rewarding to be working with the Public Health Law Network to bring this together, and it's just nice that you're all here to be able to share this information. Part of what I'm going to be talking about are the barriers and opportunities that are created through the school policies or the laws or whatever that cause us not to have a school nurse in a school or allow us to have a school nurse in a school. And I certainly appreciate our two speakers before us, so three speakers actually, because I mentioned to Dr. Mon, Erin Mon, that it was so nice to have Dr. DePinto up here sharing what school nurses do. They get it. They get school nurses. So thank you for sharing that. And then the roles that you may not always think about connecting with a school nurse, but that Robin and Susan shared, that's what school nurses do. We look at the whole practice within our school community. So I really appreciate you sharing those. But to me, you know, the glass is always full. I don't look at barriers. I mean, if you have a barrier, that means there's an opportunity. So we're going to look at some of those as we go along. And Donna mentioned that the National Association of School Nurses is a membership organization. We currently have around 16,500 members. It does fluctuate, but we have an opportunity to get more. And that's it is one of our strategic goals, and we will be working on that as we move forward. But with a brand new study that is just out from the University of Washington, gives us the percentage of schools that employ a school nurse. And these are the numbers, both public and private schools. Almost 40% of the schools have a full-time school nurse. Part-time school nurse, they're 35%. But look at that, 25% of the schools do not have a school nurse. And I always just think to myself, what do they do? How do they, how do they care for the children in their care? It's mind-boggling to me, hence this is my passion. The student population has increased 26% from 1985. We have more children in our schools. Interestingly, the special education population has gone down slightly. Now, I've been a school nurse for 30 years, and I can tell you that the practice has changed over the years. And we do have, over the years, have had more special education students in our school setting. But since 2002, there's been a slight decrease in the number. But those children with other health impairments, 50% increase in children with other health impairments that would qualify them for the special education. And the reason we talk about that, because when you think about the children that are in special ed or that have the other health impairments, those are the ones that need in addition to our regular education, but those are the ones that maybe need our services of a school nurse a little bit more. They need the support to be able to succeed in school. And all of this is related to their access to education. We want to level the playing field, remove the barriers so that they can succeed in school. And as Dr. DePinto mentioned at the beginning, several federal laws set this up. In 1975, the Individuals with Disabilities Education Act, which allowed children to come to school to have access to free and public education in the least restrictive environment. And these laws have been amended throughout the years, and we've seen more and more children with special needs come into the schools and into the classroom. But probably around the 90s is when I really started to see it where I am. I'm from Delaware. The least restrictive environment. It took a little bit of a time to really embrace that. But now, rather than having students with special needs in a separate population, then they were required by law to be in their least restrictive environment, which has been wonderful for the children that come in with their peers. They're there being educated with their peers, which is the way it should be. But I mean, they're coming into the schools. The other piece that happened was the Section 504 of the Rehabilitation Act. This was the Office of Civil Rights, which says that if someone has a qualifying disability that impacts their activities of daily living, that we need to make accommodations for them. That applies to schools as well, so that we can make accommodations for our students so that they also have a level playing field if it impacts their activities of daily living. And school nurses are very involved in the process of making the accommodations for our students. Well, let's see, I don't want to go back there, I want to go back here. And part of that includes being a member of the IEP team, the individual education plan, that if a child does have other health impairment or if they have been identified as needing special education or may need that, the team meets, but if they have a health issue that may impact some of their learning, the school nurse is required to be part of that team. They are listed in the law as support personnel, so that they need to be on that IEP team, helping to plan the accommodations for the students. And, you know, school nurses, we kind of look at the whole picture. School nurses look at the whole child. So we bring a different perspective than what perhaps the teacher may be seeing, or what perhaps the physical education teacher may be seeing. We bring a different perspective. So it is very important that school nurses are part of that team. So that kind of sets the stage for where school nurses are and what they do. So now we're going to look at barriers, and I want to tell you that in red, funding, that's barriers. Anytime you see anything in red, that's a barrier. My code is in green is an opportunity. Well, this recent study out of the University of Washington, they said that the schools that did not have a school nurse, 64% of them noted that cost was a barrier. So cost, and we know that cost is a barrier because the majority of schools are funded by education dollars. Some get a smaller percentage get public health and some Medicaid funding, and then a smaller, even very tiny percentage get funding from hospitals or local community agencies to support school nursing care. But the majority comes out of education dollars. And we know that when money gets tight, education budgets shrink and services are cut. And the business of education is to educate students, although I see it as and I don't want to offend anyone here, so I guess I need to watch that, but we need to think long term, and we need to meet the basic needs of our children, the health and social needs of our children, and physical needs, in order for them to be educated. If you've ever had a toothache, you cannot sit in the classroom and be learning. If you can't breathe, you're not going to get the best of your education. So, I just, you know, funding, when the budgets are cut, and just as an example, in Philadelphia, they had a really tight budget year, and they cut most of their nurses from their program. Unfortunately, they had a young lady, 12-year-old, die of asthma. She went home at the end of she had an asthma attack, and no one really recognized it, that she was in the distress that she was in. And someone came and picked her up. Her dad came to pick her up, but she died. We don't ever, ever, ever want that to happen, which is why we advocate so much for the services that school nurses can provide. And the other barrier is, well, and this isn't a barrier, this becomes an opportunity, but Medicaid does reimburse for services in the school setting, but only 48.6% of the public schools are accessing the funding for Medicaid. Now, when this first came out, I think we had more schools accessing funding, but there was some confusion around what was happening with the funding. And I believe you're going to discuss that later? Okay, great. So that's, Susan's going to discuss that later. But this Medicaid looked at the schools and said, wait, we gave you this money, we need to take some of it back. So the schools got a little bit gun shy. Well, wait, we can't invest all of this and then have to give our money back. But now, in 2014, they reversed a ruling that allows more money to come into the schools. And schools are now starting to start back up and do more Medicaid billing, but clearly we have an opportunity there. So our opportunities, our federal programs, Medicaid. So we do have a huge opportunity to bill for direct care and other services for students in the school. And Every Student Succeeds Act, another, as Susan went over, the Every Student Succeeds Act. That's a new law that came into, that was passed in 2015, and school nurses are listed as others specialized instructional support personnel throughout the law. Susan just gave us an overview of what school nurses can do with attendance around asthma outcomes, and we do have data that shows that school nurses managing asthma improves the attendance. But in 1900, the first school nurse was placed in the schools by Lillian Wald to improve absence. That's where our groundwork, that's where we come from, to improve attendance in schools. And it made a difference in a year, and in 1 year they doubled the number of school nurses in the schools. So it does make a difference, and it is an opportunity for school nurses. But we also manage chronic conditions, and there is information in the law that school nurses lead the management of chronic disease, children with chronic diseases in the school setting. So we are mentioned in the law. Did you need something? Okay. Thank you. Appreciate that. The other opportunity, and it is an opportunity, and I put them both up here because we don't know what's going to happen, but things are happening, is with the Affordable Care Act and the American Health Care Act. Both of them believe in the triple aim, the improved population health, improve the patient experience of care, and reduce per capita cost. Both of them believe in that. So moving forward, it's just something that we're watching. Now with the American Health Care Act, this came right out of their mission statement that they want to improve choice, promote innovation, and strengthen the safety net for the most vulnerable. What we don't know, and this was in the Affordable Care Act, we know about the preventive care coverage and how important that is for children, and that's where school nurses do so much around preventive care in the school setting. We know how important it is to make sure the child has their immunizations, make sure that they have early identification for vision difficulty or hearing difficulty or even emergent illnesses, how important it is for that early intervention, and then the preventive care. But also Medicaid expansion. The states expanded Medicaid, which then allowed schools to receive the funding, but it also allows the children to get the Medicaid so that they can get support for the services and get the care that they need. At this point in time, and it's just unprecedented, 95% of the children in the United States are covered by health insurance. And we are seeing that benefit in the schools. We are seeing the ability to get our children in for care, preventive care, and keep them out of the emergency room. So we are seeing that. We don't know what's going to happen to that, and that is one of NASN's legislative priorities, is to make sure that we do still have the Medicaid coverage for our students. And then, of course, what was required in the American Care Act, and which is a positive that has happened, is that community assessment. And I didn't see that there was anything that related to that, but the hospitals are required to, every 3 years, do a community needs assessment and look at their community and see how they can improve care. Well, because of that, many have partnered with school nurses in schools to coordinate care across the country. That has really improved the care and the care of students and the coordination so that we're all on the same page. So those are the positives. Back to my red again, in the barrier, the models of school health services and the state laws and regulations. I know Alex is going to be talking a little bit later about the state laws across the country that she has researched. But the requirements for health services are different across the country, very different. That some states require a BSN and certification, and it must be an RN. Other states, there's no requirements whatsoever. So there lies some confusion. 1 minute? Oh my. Okay. I'm just talking away. Let me just keep going. So there lies some confusion. Then the Nurse Practice Acts. Can you delegate? Can you delegate medication and administration? Can a school nurse be an LVN or an LPN? NASN advises that it must be an RN with a bachelor's degree in nursing to be a school nurse. And the other piece is supervision by non-nursing personnel. That traditionally, nurses are supervised by principals in the school setting who are wonderful people but don't understand the nuances of nursing practice. What is nursing practice? What is and what is not nursing practice? So then there's some difficulty in delegation of care, that if a principal says, you give this pill to this student, well, a nurse knows, whoa, no, we don't do it that way. It has to be in the original bottle, and we have to have permission from the parent. There are laws and guidelines regarding this. So there's some confusion as to what we can do and what we can't do. And again, the scope of practice, just like you heard about the environment, that is within the scope of practice of a school nurse. So we can do so much more. We do not sit in the office and wait for people to come to us. We have a broad range of practice areas that we are able to affect change and make a difference in the lives of our students. Opportunities is a framework from the National Association of School Nurses. This opportunity is for us to be able to share with others what it is that we do. This came out in 2015, and there are concepts that are interrelated that really describe what it is a school nurse can do. And we've been helping school nurses understand how they can use this framework to inform others what they do, so that the non-nursing personnel can understand the scope of their practice and what they'll be able to do for students and improve students' care. And of course, the WISC model is from the CDC and ASCD, which involves partners in the community, not only in the community, but also in the school, so that everyone is working together towards the health of the students. You can't do it alone. None of us can do it alone. We all need partners within the school setting. And this is a new model that has really helped us kind of frame up what we need to be doing. Whoopsie, I'm almost done. Next, where's the next? Communication and collaboration. We have been in the hidden healthcare system. School nurses have long provided care in a hidden healthcare system, but now we are coming out of the shadows. We are coming out of the shadows. A lot of that has to do with the collaboration from the health assessment with the hospitals and the care coordination. But also schools, colleges and universities now are an interdisciplinary practice. They're working together so that they recognize that they can't do it alone either, that it takes all of us. And school nurses are members of that team. Electronic health records don't communicate between schools and hospitals, but that's a possibility coming up. And of course, HIPAA and FERPA that Dr. DePinto mentioned. And I wanted to talk about Nemours Link just because in Delaware we are able to communicate with the primary care providers through, we don't communicate, we have access to the electronic health record. They work through FERPA and HIPAA. It's a wonderful program. Nurses are essential members of the healthcare teamers and are able to get the information that they need off of the record so that students have up-to-date information and we're coordinating care. It has really improved the coordination of care. And that's happening in pockets around the country. And Nemours has a slideshow and information that they will share with those of you that may be interested in this. We cannot print out and give information. We can only share verbally. The relationship is with the nurse, not with the school. So that health information is with the nurse, not the school. That's who the agreement is with. And then, of course, data. Data is an opportunity and a barrier. We have some data. You've heard little pieces of it around asthma and some of our educational outcomes. But, you know, we have a health system and we have an education system. We meet the health outcomes. We also need educational outcomes. 64% of our budget comes from the education system. We need to prove and show through data that this is what we can do. Data talks. So, with that, I'm going to turn it over because I always see the glass is flowing over, and it will be flowing over. as we move forward with all of our advocacy efforts. So thank you all.
Hi everyone, I'm last, so don't leave yet. I got to pull this up. And I'm Dr. Erin Mon. I'm the Director of Research at the National Association of School Nurses. I'm going to kind of pick up where Beth left off as soon as I figure out which of these is mine. I think this is it. Okay. So in my presentation today, I am going to talk about outcomes, but I'm going to start by talking about data. And I'm doing this a little differently because I want to frame it, and I realized my assumption even as I was sitting here, which my brother, the lawyer, would be mortified, but well, he's a patent lawyer, so that's okay. So when I think law, I think money. So around this, and I don't know, lawyers may or may not agree with me, and that's okay. Again, this is my perspective, but it was an assumption I made when I was developing this that I thought was important, and I'm just sharing it right up front. Because in my experience as a school nurse and as a state school nurse consultant, and now as a researcher, is that laws are great, but oftentimes if there's not the money connected to those laws, especially in public health, the laws don't do what they can. There's no teeth to those laws, or in some states, for example, I know in one in particular where there is a law that they need to have school nurses, the penalty that they have to pay not to have it, they prefer to pay that because it's less than employing the school nurse. So I bring that up because I think that's important as we look at this, is that laws are really important, but it's that overall structure, and so I'm going to talk about and kind of frame it in that perspective about data and the money and how it all ties together. Because doesn't everything tie into money? No, just kidding. Anyway, but I want to start with some data. Beth mentioned, and Donna did as well, that we have the workforce study that it's just now coming out. It hasn't actually been published in a journal yet. We're hoping to get, tomorrow is National School Nurses Day, so celebrate for everybody. Yes, I know, isn't that great? And we hope to have one of the first infographics published tomorrow, if not very soon, but I think it'll be for tomorrow, that will share some of this data, and then it will be forthcoming after that. It was a national study that was done. We hadn't had one for nearly 10 years, and it was stratified, so we had both public and private schools included, and the University of Washington was the university that was commissioned to do it, and gives us some great insight. That's how we've learned how many school nurses there are. I want to share a little bit more going on from what Beth said. And this is my favorite slide. Yesterday I was so excited when it was done. But let me explain it, because I think this also is the key of why we need to delve down. So we know overall that there are the 95,776 school nurses, FTEs. Donna mentioned that. Beth mentioned we know that some schools have a school nurse, some are part-time, some are full-time. This slide here, these numbers, for example, so I'm a New Englander, go Patriots. Sorry, I just had to share that. I was the one clapping down here. That 91.5% of the schools in the Northeast have a school nurse. We've always known that they've had a higher percent. That's where I grew up. That was my model of school nursing. I practiced school nursing out here in the West, where 74% of the schools have a school nurse. It could be a part-time or full-time. So looking at it, you know, other than the Northeast, who's well above, the other ones aren't that bad, but the data we were able to share really gives us a really, and I don't know if you can read this well, but I'm going to share it. So actually, the reason the South is actually the darker color is because of the school, 60% of the schools have a full-time school nurse, where 14.5% have a part-time school nurse, but then 24.7% have no school nurse at all. So it averages to 75.3%. But can you see the difference when you delve into it, and how important this tells a completely different picture? So in the Northeast, it averages to 91.5% of schools have a school nurse, but actually only 46.7% of them have a full-time school nurse. 44.8% have a part-time school nurse, and only 8.6% do not have any school nurse at all. That's a little different story. The Midwest, it's 32.7% have the full-time school nurse, where 38% have a part-time, and 29% have no school nurse at all. My big shocker is when we come to the West here, because 9.6% have a full-time school nurse. That's a little different, isn't it? Tells a different story. 54.4% have a part-time school nurse, and 36.0% have no school nurse at all. That's a really different story when we delve down into it. And that's an important story that is a barrier as well as an opportunity, because when we know this, there's things we can do about it. And it influences the outcomes that a school nurse can have. I'll say right up front, we don't have the data that we would like to show, with the rigor that we would like, I should say, regarding outcomes. We do have data, and I will show it to you, but this is one of our challenges, is because it's the model of school nursing that is such a key factor. For me to compare a school, and we just pick a school in the West, well, the likelihood, according to this, of it maybe not having a school nurse or having a part-time, and comparing it to a nurse in the South, which we know 60% have, that's going to tell a different story. So it's one of those things we do need to definitely look at as we move forward, and how and why this occurs. And laws do have a lot to do with it, as well as money, as well as a lot of other things. Also, looking at it from a public school versus a private school, 81.9% of public schools have a full or part-time school nurse, whereas the private schools, only 34.6% of them have a full or part-time school nurse. Again, there's an opportunity there with laws and regulations and other things. Medicaid. So Beth mentioned 48.6, I think it was, of public schools. Nationally, it's 46.2%, because there are some private schools that actually do bill for Medicaid. But broken down across the different regions, you can see distinct differences in how and who bills for Medicaid. Activities that a school nurse does, and this is where it brings into outcomes, since I spent a lot of time on that first slide, but I think it was so important. But the percentage of time, you can see that the far majority, oftentimes school nurses do provide a lot of direct care, but they also provide a lot of health education, that's the blue here, and doing other things, and understanding this full scope of what school nursing does. And so these are just some of the various activities that you can see that very much are public health oriented, that I always think of school nurses as the eyes and ears of public health, and I think they're the eyes and ears of the healthcare system too, but they're not technically connected to either one, and that disconnection is sometimes what causes the problem. I also have to throw in this, because I'm a public health nurse too, is we've seen quite a few pyramids today, so here's another one for you. But I think as we're looking at laws too, is looking at the laws that are going to have the greatest impact. And the beauty is that school nurses, we address those social determinants, which may have the largest impact of a population, while at the same time moving up the ladder, also doing the counseling and education at the individual school nurse level. So it's a way, as we're looking at different policies and different things, looking at it from different perspectives. So what is the outcome? What do the data show? It was mentioned by several people about immunizations. And I'm bringing up the money of this. There's the Minnesota outbreak right now we're working with. Herd immunity is a huge issue we need to deal with. Because I'm bringing in the money perspective of it, past research shows for every dollar that's put into vaccination, $16 is saved. But that's when you look at it from an illness perspective. There's been a recent study, and it's in low and middle income countries, so take that into account. But when they took into other things into account, things such as quality of life, the whole community, that kind of thing, they actually found that for every dollar that went to vaccinations, $44 were saved in community savings. So when we think about where dollars are going, we need to look at things a little differently, and there's quite a bit of evidence that shows when there is a school nurse, immunizations go up. They go up in compliance, because school nurses are that trusted person that can explain to parents the importance of immunizations, and they're more likely to do so and get them the need they need. At the same time, they're also setting up school-based vaccination clinics. And the studies have shown that that increases vaccination compliance, flu compliance shots as well. But also they found that then there's a link of decreasing the absenteeism in the schools. So it's a direct link to helping in the schools as well. Mental health was mentioned. I think we oftentimes don't realize how many children are affected by mental health, and that they're identifying at a younger and younger age. They estimate an annual cost of $247 billion from the impact of child, family, and community because of the early onset and the prevalence more and more of various mental health disorders. And we know we have the evidence that school nurses are a huge they have a huge impact in identifying early those students and children that might have a mental health disorder, as well as managing it. We're not saying that we're the counselors like a school psychologist. I'm not saying that at all. But there is the role of the school nurse, and we estimate that about a third of what school nurses see from children are oftentimes more of a mental health concern, and it could be everything from the child that's having a stomach ache and a headache and they don't themselves connect it to the stress and situations for which they live, to much more severe mental health concerns. So chronic conditions, because when we think school nurses, we oftentimes think of chronic conditions, which is a huge part. Here, we don't have good data on how many students, school-age students, have a chronic condition. So that alone, this is actually, we have a joint project with the National Association of State School Nurse Consultants, where we're collecting and have uniform definitions of certain things in schools, one of them being chronic conditions. And what we showed, the blue is our Step Up and Be Counted data, the red are the national samples, because they are samples. And so that's why you oftentimes get huge variances, because it depends on the study. We're trying to, and this is the role I think that school nurses can have, again, as the eyes and ears of public health, really know how many students have various chronic conditions, and then be able to address them, and more importantly, then because we have the data at the school level, be able to do the rigorous studies that we need that show this intervention actually does make this difference. So setting that up, also, there's a definite link of the social determinants and health disparities among children that have chronic conditions. A huge part of public health is addressing those social determinants and health disparities, as have been mentioned. CDC also did a study that they found, again, bringing that money tie-in, that for each child with asthma, diabetes, or epilepsy, there's an additional cost of $1,377. I can't speak today, $1,377 to $9,059 per child that is added to additional medical costs. So again, as we're thinking money, we need to think of where the money is being spent and how can it maybe be done in a different way that would better help all our students. And we have the outcomes that show that a school nurse does impact and improve attendance. I can go into more details on that later if you want the exact, but the evidence is there. The evidence is also there when there's a school nurse, the child is more likely to stay in the classroom and in school because they're not being sent home, which is another key part of that. And finally, because we're talking money, I want to end with these studies that actually show the return on investment. This study was done looking at time, and then they converted it into dollars. That a school nurse saves a principal an hour a day when there's a school nurse there. They save clerical time about 46 minutes. When you figure that out from a numbers perspective, it's for every dollar that's spent, $1.84 is saved in the schools on education and education personnel. The Centers for Disease Control, CDC, took data from Massachusetts, and this is just on treating. It doesn't do anything about health prevention and all that we know that school nurses do. It also doesn't address 911 visits or hospitalizations or attendance. Just looking at treatments that are done in the school, it boils down to, I can share more about this if you want, but for every dollar that was put into school nursing services, it saved $2.20. So we know that having the school nurse saves money, but there's always the issue and the barrier of, well, we don't have enough money for school nurses. So as we're looking at it from a law perspective, and again, because I connect law and money, looking at, well, maybe it's a reallocation of where that funding is. And there's a lot of discussion about prevention, and as someone who does a lot with children, it amazes me, they talk about upstream prevention, and then they start with the Medicare population. Which is your older population, which I think we should also address. I'm not saying that, but if we want to do upstream, let's start with the children and the early intervention where we know they'll make huge impact on society, both from their outcomes as well as saving money. So I want to go back to this wonderful pyramid that I love. And why I bring it up again is that I think as we're looking at laws and interventions, we need to look at them at all the levels. We need to look at that. We oftentimes think of school nursing up here with the counseling and education, which for sure is a huge part of what school nurses do. But they have just as much impact down here where we can have the largest impact by addressing those social determinants, the lack of access to care, and which means not just not having health insurance, but it's means finding a provider in that community that's going to take Medicaid that we've struggled to get the family on when all of a sudden all the providers that take Medicaid are full, and it happens all the time. But that's where a school nurse also comes in and addresses the environmental factors. I was making a list as everyone was talking like, oh, there's another one. Those systematic changes, sharing of electronic electronic healthcare records. If we're going to have one seamless healthcare system, then laws that address that are important. Also, even, I know there's several educators here, and how we can change education so that in public health nursing and the interprofessional, with law, with education, with environmental, with all these we all intersect and we learn it on the job, but if we could be done right, starting with education, and we might not think of that maybe as a law per se, but I'm thinking it as guidelines and how we can just change and help the system. The data sharing for sure. Prevention, I think looking at, there's a lot of opportunities like Beth mentioned with value-based care. I was on the phone with a parent yesterday where she was asking me about data, but it got to a discussion of how can we look at and put in money from healthcare systems or large employers of the community into looking at money differently to help with the cost of the school nurse that would then help with the cost of the entire community. So it saves money, which is an outcome, but also is also addressing the healthcare needs of the student and of the families, because oftentimes school nurses also help families as well. It's not just the student. All the way down to the individual student as well, because we never want to lose those. So this, I love this quote. It was actually Jamie Oliver, yes, the cook, was concerned about a bill that was going on in England about nutrition in the schools and stuff. And I just thought this fits so well. He was talking about the nutrition in schools, which is part of this, but he's like, the public health of 5 million children should not be left to luck or chance. And I think that's what we're here about, is it's not about luck or chance. We have an opportunity to thoughtfully look at how laws and guidelines and money impact the healthcare system of our students through school nursing. So those are the references, because I know we're going to have questions, but I knew I was last, so I'm going to keep this slide up as we think about it, because it's easier to build strong children than to repair broken men.
Okay, thank you, everybody. That was great. We actually have exactly 5 minutes for questions. If you all could do me a favor and briefly repeat the question, because we are live streaming and recording, because the question won't be heard before you answer. Any questions?
Hi, good morning. This isn't a question, but just a comment about how each of you could present a day-long seminar on each of your topics. I, first of all, so greatly appreciate the reference to delegation, and for those of us who have to deal with delegation issues, especially non-nurses who are deciding for us what we can and cannot delegate, it's just on, and it goes on and on and on, and it keeps my head spinning. I mean, and environmental issues. I've had 2 schools with very severe mold, asbestos, aspergillus issues. Money. Nobody wants to hear about it because of money, and it costs a lot. And you're standing there by yourself saying, "But everybody gets headaches." How many of you have heard that from your? How many people say everybody gets headaches? No, that's not the reason they're getting headaches. Absenteeism, and it's not just the 10% a year, it's the kids who come in and miss first period every single day, leave at 2 o'clock every day, but, come in at 12 so that they can play football or be in the school play. And then you wonder why when they leave, they don't succeed in college, or don't know what it means to punch in a time clock and arrive to work on time. Did I take up my 5 minutes? Okay. I could go on. Anyway, thank you.
I do have a question. We're looking at all these indicators, from ESSA, and looking at the chronic absenteeism, and looking at the environmental. One of the biggest challenges I'm going to see that is going to come to head, and I've been thinking about writing a little blog post about this, is about when you just discuss head lice and chronic absenteeism. How are we seeing this going to move forward to change the mindset to best practice and evidence-based practice? Any of you, actually, because it kind of crosses across all lines.
Well, I'll just briefly state that from the standpoint of the American Academy of Pediatrics, we really advocate removal of the no-nip policies. And we had a policy statement come out, I want to say a year or two ago, that really made national headlines because of the controversy around NITS. But if I take my AAP hat off for just a moment and just tell you one effort that we had in Maryland around our state guidelines around NITS. So we worked very closely with our communicable disease unit in our state health department to really help impress upon the proper messaging around this issue. But we used one county as a sort of pilot, let's say, for undergoing sort of an evidence-based practice process where we reviewed the literature, created some messaging around it, helped them revise their policy. They rolled out the revised policy with very little fanfare, and nothing happened. I mean, it was not, I mean, they had very few backlash around it. And so when we put in our state guidelines that we no longer support a no-nip policy, again, there was very little backlash about that. So I think that sort of being very deliberate and acknowledging the fact that NITs are not a public health issue, they do not, spread any kind of diseases, and being able to have the right messaging with the data to support the policy is a really important mechanism for being able to change people's minds around it.
And I just want to add to that NASN also has a policy about no NITs, and we don't recommend that children go home if they've just been discovered with head lice during the day. They've likely had them for quite some time, that they can wait till the end of the day and then go home and be treated. But what we found is that really it's a matter of education, that we really need to educate our families and our communities, our staff, about it is not a public health issue. It can be treated, and we'll help you. We'll walk you through this. We'll help you as you work through this. And it really is communication and education.
And I'd like to add that, and not just in the situation of lice, but in more broadly thinking about when should parents keep their children home and when should parents send their children to school. What we've known from communicating and surveying and talking with families across the country, that there are wide varying practices and community norms about when parents choose to keep their kids home and when they send them to school. And nurses and nurse practitioners can make a huge difference in helping to educate families about NIT policies, about runny noses when you're 5, and a variety of issues around health, about when kids should be in school, and also when families should communicate with the nurse and the school community about concerns around physical and behavioral health, so that we can get proactive interventions in place when there are more serious issues. And so we see nurses being instrumental in that education and awareness raising.
And I'd just like to add, is this on? Regarding environmental health, prevention is always better than treatment.
And with that, I think too, is as was mentioned, I think sometimes we put too much focus on lice because people understand lice and they think that's a huge part of what school nurses do, but it's not really a public health, it's a public health nuisance, that's for sure. But I think it can be, and in tying all this in though, is I think it's an opportunity where school nurses shine in addressing the social determinants and the home factors that are really oftentimes the issue behind lice, runny noses, or whatever it is. And sometimes I think it's turning our message to make sure that we're focusing on what school nurses, what we really do, and it's focusing on why they're being absent, which might be the treating lice, but it's really addressing the home factors and the family factors that are also impacting probably other reasons why that student's not in school.
I only bring it up because it is a concern that we hear of a lot, and with the challenges that happen that school nurses have with their administrations, that's where it all comes into play. And in everything all of you have said is where, things as this, we can make a change in and, reduce the absenteeisms and, go to a preventative measure and everything. But we just have to really, like I said, I understand the educational piece, but it's getting all administrations to not always been to the public outcry of concern in the same manner, and educating the parents as well in the community.
Okay, everybody, I'm going to cut our questions short, but we actually have a keynote address for you guys to kind of rile you up. I'm really, really excited about him. So a little bit about the democratic process here. I did not build in a bathroom break because I thought that we could just be kind of fluid and move around and go to the bathroom if you have to. But I forgot how hard it is to get in and out of these seats. And so democratic show of hands. Keep cutting out. Do you want to take a 5-minute bathroom break? Put your hands up if you want to take a 5-minute bathroom break. Can we use the bathroom? You can use the gender-free bathrooms, and you can use the women's rooms. There are several restrooms that are available. So let's take a quick break of 5 minutes. Please be back in the room at 5 till, and you will hear from Dr. Durant, and you will be fired up. Okay.